Live from the Washington, D.C. area, it's the Inside Scoop. All the news that our viewers want to know. Now, here's the host.
Welcome to Inside Scoop. I'm your host, Catherine Reed. Tonight we're talking about community health care here in Virginia. Joining me is Dr. Basim Khan, who is the Executive Director of Neighborhood Health. Welcome, Dr. Khan.
Thank you. It's great to be here.
So Neighborhood Health is celebrated its 20th anniversary this year. So congratulations, first of all, on that.
Thank you. Thank you.
And in a manner of full disclosure, my husband, Tom, happens to be on the board of Neighborhood Health and has been for many years. And so my knowledge of Neighborhood Health stems somewhat from the work that you do and also the fact that he's been invested in the work that you do. So tell us a little bit about the genesis. I think the story of how Neighborhood Health got founded is fascinating.
It is. It's a great story. 20 years ago, the Alexandria Health Department noticed that in a community in Alexandria, Arlandria, it's on the border of Arlington and Alexandria, there was a lot of need among immigrant mothers and their children in terms of healthcare services. So people in these communities or in this specific community didn't have access to basic healthcare. So they set up a small program to provide basic preventive care in an apartment complex. So it's within the same apartment complex in which a lot of these families lived, and they provided very basic services. And it was funded by a federal grant that ran out after a few years, but when it was running out, the community came together and decided to form a nonprofit organization. It was called Alexandria Neighborhood Health Services. And through that nonprofit, then this organization just grew over the years. So we became what's known as a federally qualified health center back in 2004. And then with that, the services that we provided continued to grow. So we provide basic primary medical care. So that's both pediatrics and adults, from newborns up to old age. We provide dental services, we provide mental health, and what we like to say is that we're a primary care medical home. That's a term that's used a lot in the industry. And what that means is that the services that are provided to these patients are very broad. It's primary medical care, but in addition we do labs, we do case management, we provide access to medications. We are integrated with mental health, and we help navigate them through the healthcare system, which is increasingly important. And the important point here is that we do it broadly speaking. So we provide it to people who don't have health insurance, people who do have health insurance, and most of our patients are actually low income who wouldn't be able to get these services anywhere else. So over the last 20 years, we've grown a lot. When we started back then in that small little apartment building, we were serving 1,500 patients in 1 year in just one clinic. And now we've grown to 12 clinics across Northern Virginia, Alexandria, Arlington, and Fairfax County. And we just saw the numbers from last year, 2017, and we served 18,000 patients.
Wow.
So a huge growth, and with more to come, hopefully, as well.
And this is about creating a medical home where people can get affordable health care, quality health care, and it's accessible to them. Talk a little bit about the problems of accessibility.
Of course, and I think that's probably one of the largest problems in healthcare, obviously tied into cost as well. And what's interesting there is that the Community Health Center program is a broad program across the whole country. It started in the 1960s with President Johnson's War on Poverty. There was a community health center that was started in the South and then one in the Northeast. And then since then it's grown. So there are 1,400 health centers across the country. In communities everywhere, rural, urban, and they're all nonprofit organizations that are independent nonprofit with a board of directors, but then also get federal funding and then funding from other sources to go out and raise money to be able to do this. The issue of access to care, as we know, is a major issue because healthcare has been in the news so much, and many families in Northern Virginia and across the country really face this, because when you're low income and you don't make much money, in a lot of these jobs you don't have health insurance, or small businesses, for example, who don't have health insurance. And for people without health insurance, it can be really challenging getting health care, because if you go to a doctor's office, they'll charge you a fair amount to be seen, let alone for labs and follow-up testing and medications. And so what we've seen is that many of these people go without basic health care. And by basic health care, we mean, just the real basics, like preventive care like cancer screenings, mammograms, pap smears, access to medications for basic chronic diseases like diabetes or hypertension or heart disease. And what happens is that they just go without a lot of these medications, without a lot of these services. People eventually may get sick and then they wind up in emergency rooms. And usually a lot of the time it's too late. Something's happened like a heart attack, or sometimes people get diagnosed with cancer and you realize the importance of getting preventive care in the beginning all along. And so that's what we help them do. For patients who make less than 200% of the federal poverty guidelines, which I would say for a family of 3 is $40,000 around there, we're able to provide really deep discounts to get access to primary care. So visits are anywhere from $15 to $50 for medical services, depending on where they fall. So we have eligibility to make sure they fall within those income guidelines, and then we help provide them with a whole bunch of other services. Lab services, for example, are part of the package. We help them get access to low-cost medications. Sometimes medicines that cost thousands of dollars, we're able to get them for a low price as well. So really help them get access to care. And then the things that we don't provide, like specialty care or radiology services, we help them navigate the system. So we can help them find different places where they can get discounts for these services or get them for free. So we like to think of ourselves like the patient's advocate in a really complicated healthcare system.
And you're so right about that. What's interesting about the model you describe is it's the model that Kaiser has. And the only reason I know this is because my millennial children have Kaiser. And what young people like is the fact that everything is in one place. Your doctors all talk to each other. You have access to your records, but basically everybody is talking to everybody, and there is a core of services. And I think that helps to keep costs down.
Yeah.
Because this is a vicious cycle in that when you don't get proper immunizations and screenings, and you don't deal with hypertension or cholesterol or diabetes, you come into a crisis situation, you're in the emergency room, and who's paying for the emergency room? Mm-hmm. Is this terrible, vicious cycle. And I think truly what community health centers, what you're describing, and the fact that there are other healthcare providers moving toward this medical home where everything is in one place. The lab work, you get your prescriptions filled, and all of your doctors talk to each other. And so tell me how you think going forward technology is going to play into that too.
I think technology plays a big role in this, and increasingly more and more doctors and health centers and hospitals are embracing technology. And what it does is it allows you to capture all this data. It allows you to keep better records. What's important, though, is that technology is ultimately a tool, and it's one piece of the broader puzzle. And what you described, I think, really makes sense, which is the idea of trying to move away from a fragmented system.
Yes.
Where people don't talk to each other, because I've seen so many times where tests might get ordered on a patient that were unnecessary because the doctor or the patient didn't remember that it was done some time ago. And sometimes a lot of harm can come from unnecessary procedures that happen that way. And that communication and that coordination that you find in integrated systems, not only Kaiser, the VA is another example, is something that I think is really beneficial. And what's interesting is community health centers are, along with free clinics and a few other entities, are really the safety net, right? To give you a sense of scope, we provide services to 18,000 patients, but across Virginia, community health centers provide services to 300,000 patients. And across the country, it's 27 million patients. But even though we're the safety net in that half of our patients don't have health insurance, many of them are low income, we've also really embraced technology and embraced electronic medical records. We use electronic medical records like anywhere else, and we track a lot of our quality measures in the same way that a lot of large systems do. So we're tracking and keeping count of what percentage of our patients who need pap smears get them? What percentage of our patients with diabetes have their diabetes under control? What percentage of our patients with high blood pressure have it under control? Asthma, vaccinations, what percentage of our children have been vaccinated appropriately? And the beauty of that is, even though we're providing services to those in our society who perhaps, I would say need them most or have difficulty getting them elsewhere, the quality of the services we provide, largely because of technology, but I'd also say because of the quality of the doctors and the staff who work there, I'd like to say is equal, or in some cases better, than you would find elsewhere. And I think that's really, really important, because going back to that original point, if you provide high quality primary care, not only does it significantly impact the quality of the lives of the people you're serving, it also means the system as a whole works better. It means that the costs are lower, and it's actually been shown that healthcare provided by community health centers actually drives costs down, because they're not bouncing between emergency rooms. They're not going to specialist after specialist, because a lot of times we end up just taking care of the issues, and we know our patients really well. So providing good, high quality, integrated, using technology, primary care really has a positive impact on the patients themselves, but also on the communities broadly speaking. And I think community health centers fill that role really well.
Oh, I think you're right, but wasn't kind of the whole idea of the Affordable Care Act to have quality measures, that it wasn't just going to be about reimbursing for medical visits, but rather offering incentives for quality outcomes, keeping people healthy, keeping them from return visits, keeping them, on the right track to good health? That should be the outcome of some sort of national healthcare plan, I believe was the idea.
It is. It's just really difficult to do. And there's so much going on across the country. And, community health centers is one part of it, but in Medicare and Medicaid, among private plans, there are these things called accountable care organizations, programs at the state level, that are trying to move healthcare from volume, right, which is, just more, to more of value, which is you're really looking at the healthcare being provided and trying to decide, okay, is this healthcare actually helping patients? And how can we tell that it's helping patients? It's really complicated, and it's really tough to do, because, to some degree, it's difficult for people at an administrative level and perhaps at the payer level or the government level to really sometimes scrutinize what's going on in the doctor's offices.
And you've got things like HIPAA regulations too, and privacy regulations. Yeah. And when we come back, after this break, we are going to talk to Dr. Basim Khan about community health care here in the Commonwealth of Virginia, and what you need to know as we move forward trying to improve the cost, accessibility, and affordability.
For all the papas out there, let's stop what we're doing and take a moment to be with our kids. They can be loud moments, goofy moments, dorky moments. It doesn't really matter. Every time dads take a moment to be with their kids, it's pretty momentous. So let's all take a moment to make a moment today.
Hey, did you know that 2.4 million loving cats and dogs in shelters and rescues need our help to find a home? Go to theshelterpetproject.org and search your local shelters and rescues. Go for a cuddle with your next best friend. Adopt.
Okay, so we drowned the fire, stirred it, drowned it again, and now just feel if it's cold.
Yeah.
Cool.
Smokey just gave me a bear hug.
I know. I already posted it.
We cannot be bystanders.
We can stop to make sure someone is okay.
We can warn someone when their drink isn't safe.
And disrupt the situation.
We can
get someone a cab.
Or walk them home safely.
We can make campuses safer for our friends.
Our roommates.
Our classmates. Our fellow human beings.
We cannot be bystanders.
We can intervene.
It's on us.
All of us.
Learn how and take the pledge at itsonus.org.
When it comes to saving money,
what?
Don't act like a baby.
Oh, it's like they're having their own little meeting.
This is so humiliating. Be the boss.
I'm the boss.
What the?
Power nap.
You were saying. And make a budget.
Let's get to work.
Need a little help?
Stacy, read back the notes.
I can't read. What's it say?
Create a personalized savings plan and get other tools and tips.
We can share.
You obviously didn't go to business school.
At feedthepig.org.
We're back to the Inside Scoop. Here again, your host.
Welcome back to Inside Scoop. I'm your host, Catherine Reed. Tonight we're talking about community health care here in Virginia. And joining me is Dr. Basim Khan, who is the Executive Director of Neighborhood Health, a federally qualified health center here in Northern Virginia. Thanks so much for being here.
Thank you.
So let's talk a little bit about social determinants of health, along with a lot of other new phrases that we often hear about. We often hear about that one, but what does it mean, social determinants?
I think it's a really important concept that I'm happy more and more people are talking about. And to fully explain it, what I'll do is tell you what our organization's mission is and how that ties into this. So our mission is to improve health and to advance health equity in Alexandria, Arlington, and Fairfax by providing high-quality primary care regardless of ability to pay. And so while we provide health care, or primary care more specifically, our ultimate goal is to improve health and reduce health disparities or advance health equity. And researchers over the years and the public health community have looked at what actually contributes to health. And what healthcare is a small fraction of what contributes to health. A lot of other factors do. Genetics is one. One's genetics obviously contribute to health. But what we call social determinants, which are things like one's background in terms of the income they make or their families make, in terms of the environment they live in or the neighborhood they live in or the zip code they live in terms of their housing, do they have stable housing, in terms of violence in their communities. Mental health is obviously in there as well. These are factors that education is a really big piece of it. Ultimately, when studies have been done, they've looked at how much these individual factors contribute to one's health, and some of these factors contribute much more than healthcare. And so that's something that I think is really important for all of us to really think about, because as a society, we spend a lot on healthcare. And if you think about our country's long-term drivers of our deficit and our long-term deficits, it's ultimately healthcare in the form of Medicare, but at the state level, even Medicaid, that is feeding this. And what you need to do is step back and think, are we really investing the resources where we need to ensure that health is improved? And it goes back to a lot of those other determinants, if you will. Housing. So what I've noticed in my clinical practice is I can prescribe someone medicine for their diabetes or their high blood pressure, or try to manage their medicines for a whole bunch of conditions. But if they don't have housing and they're homeless,
Right. So that's they need decent food. They need to live a stress-free life, a good place to sleep. Yeah.
And they've actually, I've read articles where they've looked at sort of American spending on healthcare and social services, and they've compared it to other developed countries or other, our peer countries. And our levels are equal when you combine healthcare and social spending. But what they've noticed is that in America, the percentage that's spent on healthcare is much, much, much higher, and the percentage that's spent on other social spending is much, much lower. And perhaps that might explain some of the poor health outcomes that we have as a society. So we might have the fanciest hospitals, the fanciest technologies, the best tertiary care in the world, and we do. But when it comes to making sure people have housing, when it's making sure people have a good social safety net, education, food, that's where we lag. And perhaps it's no surprise that we tend to lag on health measures because we fall behind in some of these categories. So then the question is, at a more micro level in our clinical practice and with our organization is, okay, how do we go about making a dent in that? Because we're a healthcare organization, and we, like I said, we provide high quality healthcare, and we try to provide that. We try to be really good about providing that. But a lot of our patients struggle with these issues, and especially in a place like Northern Virginia, because the cost of living is high over here. So people, you talk to anyone, affordable housing is an issue across sort of income spectrums, right? Getting education, getting, food, and just meeting a lot of your expenses is a challenge. And with that comes, stress and mental health problems. And how do we address those issues, even though our niche is healthcare? And one thing, and it's our mission, because ultimately our mission is to improve health. And the way we do it is through partnerships, because we know what we do well, but we also know what we perhaps don't do as well as others. And our organization, like I said, was founded by a health department. It was in the community, in an apartment complex. And so what we pride ourselves on are the strength of our partnerships in all 3 jurisdictions. So we have really strong partnerships with the health departments in Alexandria, in Arlington, and in Fairfax County. We work together with them on a lot of programs where we might be providing the primary care, but they might be, for example, with the City of Alexandria, provide the high-risk case management for a lot of at-risk mothers. They provide that service. There are other services like WIC services for nutrition. They're located within our clinics, but the health department comes and provides those services. The Community Services Board, which provides services for patients with serious mental illness or mental illness and substance abuse in general, they provide case management, a whole bunch of services to them, but then we provide the primary care and we work well with each other. And then a whole host of nonprofits in housing and food security. And one thing we're trying to do more and more is work with the Department of Human Services. And in Arlington, we actually just opened a clinic located in the Department of Human Services. So patients might be getting, or clients of theirs might be getting services related to employment assistance or related to aging and disability. But then if those patients need health care, we're right then and there so they can refer people to us and vice versa.
And so you've got 12 clinics, and some of them are larger and some of them are smaller, like what you just described.
Exactly.
So some of your larger clinics have evening hours, they have Saturday hours, because there's a lot of people working more than one job. And
Yes.
so even we talk about accessibility to health care, how can you get health care if they're not open when you're not working?
Exactly. And access is not just about the numbers of patients we serve, but it's about financial accessibility, which is obvious, so we try to be affordable. And a point I'd like to make there is we're affordable for uninsured who really don't have too many, if any, options to get these services. But even for people with health insurance, we're affordable. We're a provider that takes Medicaid. Many other doctors, dentists, and all don't take Medicaid. For people with Medicare and private insurance, with let's say private insurance with high copays, right? You see a lot of plans with high copays and deductibles. We slide the copays and deductibles for low-income patients. So that means we give them the same discounts that we would give to our uninsured patients. So let's say if they have a $1,000 deductible, but they're low income, we would only charge them $15 for the visit. So we would treat them as if they were uninsured until they meet the deductible. Medicare, you hear about prescription drug costs, right? We have special programs that help them get low-cost or no-cost medicine. Some of these patients are 10, 15 medicines. We lower financial barriers that way. Culturally, most of our physicians speak Spanish for a lot of, large Spanish-speaking population, a lot of other languages as well. We have interpreters. So if they speak any languages, we have phone interpreters in all our clinics, so we're able to translate into their languages. Because if you can't speak to your patient in their language, I mean, what quality healthcare would you be providing?
So let's talk about, that's a perfect lead into the concept of equity. What does equity mean? I mean, that's another term. People are like, Fairfax County has put a flag, put a stake in it and said, we are committed to equity in the county. One of the best descriptions I heard of equity was actually the executive director of Bright Paths, where I sit on the board. And she said she'd seen an illustration of 3 people standing in front of a 6-foot fence. If one of those people is 5 feet tall, and one of them is 5.5 feet tall, and one of them is 6 feet tall, in order to see over a 6-foot fence, they each need a different size box to stand on. Giving them all the same size box does not help the person who's 5 foot tall and 5.5 feet tall, only the one who's already 6 feet tall. So when you have different boxes so that you're lifting them up proportionally so that everybody can see over the fence, that's equity. And I think that's such a simple, great description of what it is.
Absolutely.
And so in allowing people to afford to access services, your sliding scale is creating a different size box.
Exactly, and that's the whole idea of promoting access to care. For some people, their barrier might be financial. For others, it might be language or cultural. For others, it might be because of, let's say their mental health, and we're able to address that in the clinic. And I'll give you one example, or two examples of partnerships that really illustrate this well. One partnership is with the Alexandria City Public Schools. And a lot of the children there don't have access to dental care because their parents are busy holding down multiple jobs. It's really challenging for them. And they're taking their child to the pediatrician, but because they lack health insurance, or just because of the stress and the lives that they live, sometimes they're not able to see the dentist. So we've partnered with the schools, and we actually bring dental services to the different schools. And this started as a pilot program. It was initially in 3 schools, and now it's grown to 8 schools. So all the elementary schools with a high percentage of children on free and reduced lunch, what we do is we take our dental services on a bus to the actual elementary school. So the children, we're able to provide them services right there. And it's not just screenings. We provide full cleanings. We provide x-rays. We communicate with the parents at home, and then some of them that need fillings or other work, we're able to do them right on the bus. So we're able to provide dental care for these children, low-income children, all through elementary school, and we're looking at middle school and high school, right in their schools. And so this through partnerships.
So this touches on my favorite subject, as anybody who watches this show knows, is community schools, because that is what a community school is. It's putting together partnerships to provide things like health care, dental care, mental health counseling, school supplies, you name it, tutoring, mentoring, and we don't have any community schools in Virginia, none. And so what you're talking about is what I also advocate for, with the school being the doorway through which these services are provided through partnerships like the one you're describing with the Alexandria City schools.
Absolutely, because ultimately strong partnerships between organizations in healthcare and social services and schools benefits everyone, and it's in everyone's interest. Because
you made your house a reality. Homeschooling yourself on loans, color-coding listings, and flushing every toilet in a 20-mile radius. If you can ace house hunting, you can do it for retirement. Get on track with tips at aceyourretirement.org.
Here's to the things that can keep us safe. Those we use all the time with hardly a thought. Those that are silently standing by to save our lives. And now, those that we carry with us everywhere we go. Many mobile devices will now bring you wireless emergency alerts, real-time information directly from local sources you know and trust. With the unique sound and vibration, you'll be in the know.
Listen, I realize that I'm not perfect, but it all really started to change because you judge me for having a problem. No one is going to know that I need help. I need help. I know that no one is going to judge me for having a problem. I realize that I'm not perfect, but it all really started to change because you listen.
Family.
Whether it's a short trip or a long haul.
Estimated time, 47 hours.
They will beg.
You're hungry? I'm happy to provide.
They will plead.
Deep fried butter on a stick.
But whatever you do, don't wimp out.
Now you're talking?
Make them buckle up.
He can't hurt.
Remember, safety first. Cheese curls second.
Are you orange?
We're back to the Inside Scoop. Here again, your hosts.
Welcome back to Inside Scoop. I'm your host, Catherine Reed. Tonight we're talking about community health care here in Virginia. Joining me is the Executive Director from Neighborhood Health, Dr. Basim Khan. Thanks so much for being here.
Thank you.
So when we went to break, we were talking a little bit about the affordability of health care and the fact that by bringing services to school children to solve their problems at the lowest level, right at the beginning, this in fact helps to improve outcomes as well as drive down costs.
Absolutely. Not only is providing access to basic primary care something that saves costs to society, like I said, community health centers generally cost less in general to provide high quality care than other places, but also the idea of partnerships, the idea of different nonprofits and different agencies, both public and nonprofit and private, understanding what they do well and what perhaps roles, what are roles that others can fill. And through strong partnerships in communities, let's say between schools, healthcare organizations, social services agencies, you're able to reduce a lot of waste and reduce costs because you're not unnecessarily duplicating things. And that's what we found with our partnerships at various levels, that it's not only is it good for patients, but it's also smart because it's the best way to actually use your resources and get the most out of your resources.
So one of the things that you do routinely, and I think it is so smart, is mental health. You have mental health counseling, but one of the things you do is you kind of assess for things like depression.
Yeah.
A lot of the root of poor health, or maybe as a result of poor health, people suffer from depression, which if it goes untreated can spiral out into other very unhealthy consequences.
Absolutely. Depression and mental health issues really underlie a lot of physical disease and vice versa, as you said. And in settings when you're trying to deal with one, but you don't deal with the other, you're not going to get the same outcomes. The cost is going to be higher. I mean, just think about it. If you're trying to manage a patient with diabetes who also has depression, the doctor might adjust their insulin, tell them to eat healthier, but if they have really severe underlying depression or stress, you can do all that, you can do everything you want, but their sugar's not going to come under control, and then their health will worsen and costs will spiral. So what community health centers like ours have done is we've integrated mental health and physical health because they really are integrated. They should not be separated. One feeds into the other and vice versa. What we do is we screen all our patients for depression. We screen all our patients for anxiety. We screen all our patients for substance abuse issues. And the important part is if they screen positive, we're able to offer them services right then and there.
On site.
On site.
Not like make an appointment tomorrow or next week or come back another time.
Right there.
Right there.
Right there. Because, as you know, there's a lot of stigma attached to mental health. Sometimes people don't prioritize it as much. Perhaps in different cultures it's seen and approached differently. And if this is so important to one's physical health, which it is, you need to be able to really make it easy, going back to that idea of accessibility and integrated care for patients. So when patients screen positive, we have counselors right there on site. And even if the counselors are in a therapy session, we actually have it so that there can be a warm handoff between the doctor and the counselor where they're able to talk and the patient is able to wait till that session's over and then they're able to see the counselor. Or our doctors are even trained on mental health interventions a little bit more so that they're more comfortable with it, because you really can't separate this out. And the beauty of this approach, and especially in the way that it's being done in our system, is let's say a patient has severe mental health illness. So let's say severe schizophrenia or bipolar disorder, they've had a suicide attempt. Then they go to the local community services board to get their psychiatric care or case management. Well, guess who provides the primary care there? That's us as well. Like I said, we have that partnership with them. So it's this whole continuum.
A continuum of care.
Exactly, it's a whole continuum of care. And what that does is it really integrates care. It makes it accessible for patients. You have your mental health counselor and your physician talking to each other. And I think it really provides better services for the patient.
I think that holistic approach to healthcare is so critical, and this is another reason why. Because in this country, they're starting to talk about death from despair.
Yeah.
Death from despair, like suicide is killing white men over 50. The opioid epidemic, where does that come from? you know? And so when you start thinking about pain management is a great example too of we don't think we should be in pain, even though pain is our body's way of saying, stop doing that, or there's a problem, there's an issue, go seek treatment. We think we should be pain-free all the time. And now that you can take a pill to eliminate your pain, it's not a matter of exercise or diet or weight management or any of these other things. Culturally, we've kind of gone down this rabbit hole of not really approaching healthcare and wellness in a holistic way and tying it to mental health outcomes.
Absolutely, and I think it's a perfect reflection of what we were just talking about, because what has happened is that we've medicalized so many other issues. So the solution was seen as a pill when perhaps the underlying reasons that got people in this situation was everything else we talked about: mental health, social determinants of health. And the easy way to deal with the problem for doctors and patients a lot of the time is to prescribe a pain medicine, right? A pain will take your, a medication, a pill will take, your pain away and make everything better. Well, look where that's landed us, right? And it's really heartbreaking because it is such a difficult situation now. The answer to this problem isn't easy. 30,000 people died in 2015, and the numbers for 2016 came out, and it's upward of 40,000 from opioids, with 60,000 for the overall death rate. The numbers for fentanyl and some of these synthetic opioids is skyrocketing, and once patients are addicted, it's really challenging. And and it's something that a lot of, as a doctor, we're able to see in our patients, because a lot of folks have genuine pain problems with pain, but now they're also addicted. And then how do you manage that? And it's a really tough situation we've gotten ourselves into.
And I think that's true when you start talking about suicide in general too. When we talk about gun deaths, and there's over 32,000 gun deaths a year in this country, and we don't necessarily talk about it as a public health issue, but the fact of the matter is it is a public health issue, and the fact that guns are a contributing factor to suicide is, again, not something that we're talking about in terms of a public health issue. I mean, so I look at the opioid epidemic and the number of people dying, and it's been that way for 10 years. The book Dreamland is such a great, Sam Keonis did a wonderful job of talking about how this started out in the Ohio River Valley and how it's spread across the country. People are paying attention to it, but it's actually been here for a decade. But so have gun violence deaths. And so talk about public health issues, and how do we talk about public health issues in a way that people can understand, how we need to be approaching them differently if we want a different outcome.
I think it's a matter of priorities. And we are really, we tend to prioritize medical care a lot. Especially the sort of fancy tertiary, high technology, which, I'm not saying I'm not a fan of that. Obviously that's important, and that's driven a lot of innovation. But, all you have to do is take a step back and think about ultimately what's important to us is health and wellness. And if truly that's what's important to us, then we really need to take a hard look at what's driving health or what's driving poor health. And issues like gun violence, issues like violence in general, issues of inequality and mental health, and a lot of things that are in the realm of public health, or even economics at times, and just economic well-being, plays such a big role in health. And addressing those issues perhaps would save resources as well, because then you don't have to pay these skyrocketing healthcare costs.
So let's talk about food as healthcare, because people live in food deserts where there is no fresh food, or it's too expensive, so they eat Chipotle or McDonald's, and
nothing against Chipotle and McDonald's.
No, of course not. I'm just saying it's as healthy, fresh food goes. Mm-hmm. People are eating things that are not necessarily contributing to their wellness. School children don't have enough to eat, and Bright Paths, we have the Food for Thought program, so we actually send food home with children on the weekends so that they don't go hungry. But a lot of those packaged foods are not necessarily the kind of foods children should be eating.
Yeah.
And so, we are not in a famine situation in America. America has not run out of food. So the fact that so many people go hungry and so many people do not have access to food that contributes to their health and well-being, how is that an issue of public policy? And if it is, how should we be addressing it?
Absolutely. It is because our diets in this country drive so much poor health. And while people who have better means are able to eat healthy, when you don't have better means or you're in really stressful situations and holding down multiple jobs and having to rely on fast food or your local sort of convenience store, you don't necessarily have the means to eat healthy. And again, if we're the long-term driver of a lot of our deficits is so much in healthcare, why can't we prioritize the things that ultimately impact health? And it's not just resources, it's also an issue of regulation, it's also an issue of advertising, it's an issue of working with schools and other entities to make sure that the food available to children is healthy as well. But ultimately, I think it comes down to priorities and political will as well. And as someone who's in healthcare, I cannot tell you how important these factors are in driving the epidemic of chronic diseases, of diabetes, of hypertension, of obesity, of heart disease, of cancer. So much of what we eat drives this, and even at higher incomes, let alone lower incomes where you really don't have access to a lot of good food.
Yeah, and you've got the issue of lead in water and lead in paint, and when people live in older homes, you are seeing in children certain diseases like lead that really impact their cognitive development as well as their physical health.
Yeah, and that's where I think a plug for public health funding, because ultimately public health is what impacts health on large scales, sometimes more than healthcare. But increasingly that hasn't been prioritized by our policymakers, and then there's a little surprise that you see some of the challenges that we are seeing when it comes to lead in water, or it comes to food, or some of these other issues that just have not been prioritized the same way that other things are.
And they've been around for a long time. It's not like they're new issues. They're just, I think you're right. It's a matter of we do not have the political will to raise these issues up and say we need to solve them once and for all.
And they're not difficult to solve.
No, they're really not. Political will. When we come back from this break, we are going to continue talking with Dr. Basim Khan, who's the Executive Director of Neighborhood Health. And next up on our agenda is Medicaid expansion. So please join us after this break.
So, same time next week?
Well, of course. Put away a few bucks, feel like $1 million. For free tips to help you save, go to Feed the Pig.
I dare you. I dare you to change the world. Yeah, you. Getting that college education. I dare you to be somebody important. Like be a teacher. Or a reality TV star. I dare you to stand up here. To call the shots. To be a role model.
An inspiration. An innovator.
To be a teacher. Think you can change my life? Make me excited about science like you? Have a career that really means something? Then do it. I dare you.
They say you don't have to be so strong. But this is my mother, my purpose. Strength is not optional. See, I lift her now like she raised me then. So I know my strength is super, but I'm still human.
Oh, look who's here.
We're back to the Inside Scoop. Here again, your host.
Welcome back to Inside Scoop. I'm your host, Catherine Reed. Tonight we're talking about community health care here in Virginia. My guest is Dr. Basim Khan of Neighborhood Health. Thank you for being here, Dr. Khan.
Thank you.
So Laura from Herndon has called in and asked a question about Medicaid expansion and whether if passing Medicaid expansion in Virginia will impact the things we've been talking about, and in what way will they impact the things we've been talking about tonight?
It would be a huge improvement. Medicaid expansion is a really big deal. And I'll just go back to the beginning. So Medicaid expansion would give families who make up to 133% of poverty, so I don't know, 25,000-ish for a family of three, health insurance. And many or most of these families are actually working.
Right.
They're working, or they live in families that are, or their partner's working, and because they happen to work for small businesses, or they happen to work, for any company that's not able to give them insurance, they work long hours, often multiple jobs, and yet they can't get health insurance. I just think that's wrong. I mean, it's as simple as that. And so it would give them access to health care beyond what places perhaps like community health centers like ours can do. Because, for example, even though we see a lot of uninsured patients and we're able to provide them with all these services I talked to you about, they might not get access to specialty care, and because they don't have health insurance. And so they really have to struggle to get access to that. It also helps reduce their out-of-pocket expenses, because once they have Medicaid, they don't have to pay sums of money for all the different healthcare that they're getting. And then there's so many folks out there who haven't been able to see the doctor at all because they don't have health insurance. So it's a really, really important issue. If you care about opioids, you should support Medicaid expansion. If you care about people having health care, a lot of people who work, you should support Medicaid expansion. If you care about being fiscally prudent, you should care about Medicaid expansion, because we're already paying the taxes.
Since 2013.
We're putting out all this money to fund Medicaid expansion in other states. But yet, somehow, even though it's money we've already paid, it's tough for me to understand why people don't support it.
Well, it goes back to the question of political will. What was interesting about John Kasich, the Republican governor of Ohio, accepting Medicaid expansion, one of the drivers was because of the opioid epidemic and having to provide rehabilitation and addiction services to so many people in his state. Now, I don't know if the current conversation in Richmond this legislative session is also being driven by the fact that we have these excessive costs driven by the opioid epidemic. I'm not going to question why they're suddenly coming to the table after all this time, 4 years, to talk about Medicaid expansion. But it seems to be one of the negotiating points is the work requirement. And this was something that came out of the Trump administration's. And so a lot of the Kentucky governor is rushing, to rework their Medicaid expansion to have this work requirement. What is this work requirement? How is it really going to impact Medicaid expansion?
So I think one important thing to know is that most people on Medicaid are disabled or children. So for most folks, it wouldn't necessarily apply. And
there's an exemption for that.
Yeah,
They're not going to make 6-year-olds or disabled people work. Okay.
And for a lot of the other people, like I said, most of, let's say the uninsured in Virginia who would qualify for Medicaid expansion if it were to happen, many of them are already working. So, it doesn't apply to them. So then the question becomes, well, what are you trying to achieve? And I'm all for trying to get people to work and trying to make it easier for people to work. That was a lot of our discussion around social determinants and partnering with agencies or groups that are giving people skills to work. But you need to ask yourself a question. If someone doesn't work, is it right to take away healthcare from them? And I would suspect the answer, even for people who support this, would be no. I don't see how you can tell a patient with diabetes or heart disease or someone who needs to be hospitalized that no, you can't have healthcare because you didn't work. So, and if people say they do want to do that, that's where I think sometimes the politicians, or perhaps maybe people who make policy, are really different from people who are actually on the ground doing the work. Because I don't see how this is implemented in a way that gets to their goal, which is to promote work, which is something we actually support.
Well, I think, from my perspective, that a lot of the conservative mythology has revolved around the welfare queen, and that goes back to Ronald Reagan. And the fact that there are just all these people who are just living large off welfare benefits, which there doesn't seem to be a lot of data that shows that. There's occasionally stories that come up with somebody who's figured it out. Drug testing welfare recipients, states that require drug testing welfare recipients, have cost a lot of money to do that, and it has not turned up people who are using drugs to get these benefits. But there is a narrative, and there's a power to a narrative that people have bought into, and I think it's very difficult to change.
I think it's really unfortunate, because what in effect you're doing is you are stigmatizing the people in society who probably have it, or I would say almost certainly have it toughest. And you know, to anyone who does that, I'd like to ask, put yourself in their situation. For people, anyone on Medicaid or on any, you know, low-income people, you know, I don't know how you could say they're living large.
Me either.
And, you know, I think one should be careful of that, and one should be respectful of the challenging situations that a lot of these people and middle-class people are going through. And if you want to solve problems, you don't marginalize or stigmatize people. You make smart policy, and you have to make fiscally sound policy because people have to balance budgets and whatnot. But you don't make people, you don't victimize them in that way. Or you don't
well, you know, and this comes back to issues of equity. Yeah. You know, there's a lot of people who will say, well, I worked for everything I got. I got to where I am because I worked hard. Well, that's like hitting a home run when in fact you were born on third base. You know, people start out on in a different place on the diamond.
I have patients I know who work harder than anyone I know and who yet do not have health insurance. I mean, right? And so, you know, of course you want to be in a society where hard work is rewarded, but you also want to be in a society where you take care of people who are less fortunate and who, frankly, many of them might be working harder than anyone else, but have, are faced with challenging circumstances. And, you know, a lot of these policies, I think, sometimes you hear about regulation, or you hear about sort of government being detached from what actually happens on the ground. And I would suggest that some of these policies, when it comes to working requirements for Medicaid or drug testing, actually are not really connected to the reality on the ground. Having said that, you know, I share the broad goals of trying to get more people to work and help them climb the economic ladder. And if there are ways that they can be supported through different programs, absolutely. So a lot of the devils tend to be in the detail, right? And of course, you know, you don't want to, you don't want to be in a situation where drug abuse increases.
Right.
Right. So, so I think that perhaps, you know, it might be worth stepping back, and for a lot of our political leaders to think, you know, a lot of the goals sometimes perhaps are similar, but it's the politics and the positions and the sloganeering and the media that sometimes drives people to opposite ends. And I think there's sensible solutions to a lot of these problems, because a lot of us want people to be self-reliant. We want them to rise up the economic ladder. We want affordable health care. I mean, I think people who have different political views all agree that there should be affordable health care for everyone. We want to improve the situation with the opioid epidemic. Sometimes the slogans and the positions, they'll get in the way of that.
So if Medicaid expansion were to pass, and this is probably the most realistic expectation we've ever had that it might pass, what would you or what would Neighborhood Health expect to see as an immediate impact from that?
Yeah, first of all, you know, who knows if it's going to pass or not? I mean,
let's be optimistic. Yeah, let's say it will.
I've learned to, you know, we'll see what happens. It would make a huge impact. It would mean a lot of my patients who need to see specialists, You know, many of them, we actually send them to UVA to get specialty care. Think about going to Charlottesville, 2.5 hours away, when you're paid by the hour, have to take time off work, and thus you don't get paid, may not have transport, so you have to take a bus there for what could end up being a 20-minute appointment. Just think about that. Think about if any of us had to do that with our resources. So with insurance, many of them might be able to see local specialists because they have insurance. They would be able to keep more of their money because the cost sharing would be less. It would provide us with some resources where we can grow and serve more people and then reach more people who might be uninsured or have other barriers. You know, I think it would have a huge benefit. And like I said, you know, we're already paying the money for this too. So, you know,
and we're paying it to people in other states.
Yeah, it makes sense on so many levels. So, you know, I'm a huge proponent. It can be called something else. You know, it can.
And it probably will be called something else.
But I just think it makes sense for a lot of levels when you peel away the politics. And that's why a lot of Republican governors and Republican states have done it, because ultimately it's better for their constituents.
Do you have an opinion about the bill before the legislature about nurse practitioners?
I think when you're in a situation where healthcare costs are really high, you want to be able to encourage as many folks to provide healthcare as possible. So generally, I'm very supportive of nurse practitioners, not only in primary care. We actually have a lot of nurse practitioners in our practice, but also broadly speaking across different specialties, because what we need is more healthcare providers, not only doctors, but also nurse practitioners, also, you know, physician's assistants. I'm not aware of the specific of the bill, so I can't really comment on that. But nurse practitioners are a huge part of our practice.
Well, this bill is basically rolling back some of the supervisory, the required supervisory function of physicians. 22 states have already done that. We're not one of them. And so this is not the first time this bill has been up. But nurse practitioners want to be able to provide the best possible health care to the limit of their training and experience. And so in states that have high rural populations and also urban poverty and marginalized communities, nurse practitioners are looking to do that kind of work. And so that's another bill that's healthcare related that's up this session, and a lot of people are watching it carefully. So looks like we're wrapping up our show. Thank you so much for being with me, Dr. Khan. People can get in touch with Neighborhood Health through the phone. You have a main telephone number, you have a website, you have a Facebook page, and people can go to any of those as a way of reaching you.
Absolutely.
Thank you so much. I appreciate you being with us tonight. Thank you for joining us tonight. This is all about community health care and what all of us need to know about how to access that here in Northern Virginia.